So as I mentioned, we actually have 4 goals tonight, and the first one was for you to meet our home health partners. The second is for you to understand the problem today in healthcare, and not just that there's a problem, but that a problem actually presents an opportunity. And Jeff Biehl is going to talk to you about the problem in healthcare, and then also provide some potential solutions and some opportunities for us as an organization. Next, we're going to then present, Dr. Blosser and Dr. Deep are going to present our proposal for population health. And you need to understand that we present this to you tonight with humility. We are building this airplane as we fly it. And we need all of you to participate in developing population health. And that's the 4th initiative is tonight, or the 4th goal is to engage every single office and every single physician in population health. And so we need to not only engage you tonight, but we need to ask you to be leaders in your office. This cannot succeed. I would tell you that administratively, we are just on fire for population health. But it can go nowhere unless every single office participates, every single physician is on board, and every single staff member, be they an RN or a receptionist or a checkout person or an MA, is involved. So that's our goal tonight, to engage everyone in population health. We all work for kind of an odd organization, and that is, as far as the country goes, we are either the largest or the 2nd largest physician-owned primary care group in the country. And so we are positioned to take care of population health and to manage population health like no one else. And really, if we look back at the history of COPC, we've been doing this since our inception. And really without even knowing. I mean, we just focused on quality, and we focused on what we thought would benefit patients. So if you go back to the very beginning, we wanted hospitalists. We felt that hospitalists were important for COPC. And indeed, they turn out to be very, very important. We thought that a common record was important. And here we are on our 2nd health record. We thought that ancillary services would be important. And so here we are providing ancillary services at a tremendous discount for our patients. And that's a benefit in population health. And then you go forward a few years, and we developed diabetes education. Actually, are any of the diabetes educators here tonight? Perfect. We developed diabetes education and asthma education. We lost money in diabetes education and asthma education for 8 to 10 years. But the physicians felt that it was important enough to offer to patients that we should continue it. Then you go forward a few more years, and we developed same-day centers. Great connected patient service for our patients. They're seen in the same record. They're seen the same day when they need to be. Go forward to TCNs. Don Deep developed a TCN program before transition of care nursing even existed, because it was a good service. It cost the hospitalist money. PCMH. All of these initiatives have positioned us for population health. And what you'll hear tonight is where all of those programs fit into the continuum of care for patients, and then where we've plugged the gaps where we think they exist. So we are just so excited for you to be here tonight, and so excited to begin this initiative. I won't go any longer. I'd like to introduce Jeff Biehl. Jeff will define the problem for us. Jeff is the president of the Healthcare Collaborative of Greater Columbus, formerly Access Health Columbus, which many of you have heard of. Jeff is also the chairman of the Ohio Patient-Centered Primary Care Collaborative and is on the Governor's Council for Healthcare Payment Innovation. Jeff has been a tremendous supporter of COPC through the years. Patient-centered medical homes are at the level they're at in Columbus, Ohio, and in Central Ohio because Jeff was engaged with Access Health in the beginning. And so we are just thrilled to have Jeff Biehl here tonight.
Thanks. So I am also a patient of Central Ohio Primary Care. And my medical home is Central Ohio Medicine. Who's here from Central Ohio Medicine? Somebody better be here. And that was one of our first medical home sites, and I receive excellent care. So I'd like to thank you for not just your site, but other sites for what you do in Central Ohio. And I couldn't echo Dr. Wolf's comments anymore. There are folks back there. Maybe I should stand over there. Any more about, is this better? Yeah. About the need to really get everybody engaged, because a lot of what's going on in healthcare is around changing of culture. We know how to do almost everything you're going to hear tonight. There's nothing that we have to invent. The payment models have been tested. The delivery models have been tested. The technology is available. So what I'm supposed to be a catalyst tonight to get our wheels turning before you hear more about your plan on how you're going to approach population health. And one of the things I'll revisit in my comments is the need to really think about the culture of your organization and how you can begin to adapt to change and making that the new norm, because healthcare is no different than any other industry. There's only one new norm, and that is change. And we often look at change through kind of a negative lens. I wish we could go back to the old ways of doing things. Well, I don't think that the societies and economies that we have nowadays work that way. So let me start off. I'm going to start off with just a few simple slides around what is the big problem. First of all, at an individual level, we have excellent health care in the United States. But at a population level, this actually just came out, we continue to be ranked in last place for all the industrialized countries. When you look at the outcomes of our healthcare system and how much we spend, which, by the way, is about twice the rate of any other industrialized country on the face of the earth. Who wants to be in 14th or whatever it is? Not me. Let's look at quality. We have huge variations in quality in our country. The darker color on this screen means the highest levels of variation, which, by the way, is not good. And if you are not colorblind, we are in a region with the highest level of variability on quality. So once again, we know what evidence-based healthcare can do to impact health. And what we have is a lot of variability in how healthcare is organized and delivered. So here's an opportunity for us. On the cost side, how many of you are in high deductible health plans where you're paying more of the first dollar? So that's a big change in the United States. And so cost used to only matter mostly to government and employers. Now cost matters to all of us as patients and consumers. This actually just came out, and if it's hard to see, this is around the cost of lower back MRIs. And look at the variability of something as simple as a diagnostic procedure. And the bigger the circle, the more variability. Well, Columbus, Ohio doesn't have a small circle. So if you want to shop around for an MRI, you might be foolish enough to pay $2,700 for one in our region. And most of us have no ability to know that. And so we're going to talk a little bit about that. So we have these huge variations in the quality of care. We have these huge variations in what is charged for care. And these all contribute to us not having a very good performing healthcare system. But you're ahead of the game. I had the opportunity to speak with you. How long ago was that? 3 years ago, when you were kicking off patient-centered medical homes? Remember when that was a novel idea? It was really hard to get that off the ground. I think you'll reflect back on this evening in a few years and say this was the start of kind of the next journey. So you're ahead of the game. A lot of organizations are just starting to even think about getting into population health and not really building out the mechanism, infrastructure to do that. So something else that contributes to our problem, these are the attributes of what influences each of our health status. And you notice that access to care is only 10%. Over 50% are the lifestyle and behaviors that we choose to follow. And yet, look at where we spend the money. Most of it goes to healthcare. So I always like to ask the question, why should we be surprised if a 15-minute office visit doesn't help people change the way they live their lives? You know, and for years we've been reimbursing providers and care teams around a visit mentality, as if walking into this room, this magic room, is going to disrupt what influences our health status. So we have this misalignment on what that looks like. And then this is something that is becoming very apparent to providers that are really buying into the patient-centered approach to healthcare. And the big takeaway is in this bottom quote, and that is a recognition and an acceptance that patients mainly determine their own health outcomes. So we can sit around and blame those, quote, non-compliant patients for their behavior, for their decision-making, for their lack of follow-through. But at the end of the day, what's that going to get us? It gets us actually nowhere, because we have to figure out how to engage patients, because they're the ones that will make the decisions that will ultimately change their health. And so that's at the core of a population health approach that you're going to be hearing more about. I like to simplify it and calling it meeting people where they're at, not meeting people where we want them to be. We have to meet people where they're at. And so we've got some information on that. So hold on to this as a culture change. Think about in your day-to-day role, looking at each person and realizing that they're the ones that are going to determine what they're going to achieve in the areas of improving their health. So I'm going to use some work that was done by a national consulting company to kind of frame a way to look at this big change going on in healthcare. And it's very disruptive. And how many of you get excited about disruptive innovation? But really, the root of science and the root of business is what's called creative destruction. That if we continue to just always do things the way that we've always done them, we'll get more of what we've got. How's that for a very sophisticated statement? If we keep doing what we're doing, we'll get more of what we've got. And so that's why we have to bring about big change, because on my opening slides, what we're getting out of our healthcare system isn't necessarily the best. So there are these three waves. You've been very active in what's called the patient-centered wave. So this is really around a lot of words on here, so I'll condense it down. Physicians really beginning to disrupt this cycle of a transactional relationship with a patient. So Central Ohio, I like to use myself as an example. Central Ohio Medicine made a referral for me, and I was a bad patient and didn't follow up on it. Well, in the old transactional system, they would have cared, right? I would have walked in a year later and they would have said, oh, did you ever follow up on that? But I got phone calls. They nagged me. By the way, good nagging. And made sure that they helped me bring to closure this referral. So that's beginning to move us into this one size fits all doesn't work. And I'm going to share with you a simple way of looking at this, that we have patients with comorbidity who are very different than patients who are marginally healthy, that are very different from patients who are healthy. And so a one-size approach doesn't work in healthcare. And so this is really what I think your organization and organizations all around the country are going to start working on. This is called the upside-down pyramid, if you haven't seen this before. The left-hand side are the different categories of patients. So think of these as the groupings of populations, hence population health. And on the right-hand side is how much of the dollar is being consumed. Well, these are called upside-down pyramids because 5% of our population that has multiple chronic conditions are eating 45 cents on the dollar. That amounts to $1.2 trillion a year. The next group are at risk. So these are the folks that haven't acquired comorbidity, but are still on the cusp of a different type of intervention. Our population is comprised of about 20%, and they're consuming 35 cents on the dollar, or almost $1 trillion. And then the last category is the healthy. 75% of our population is only using 20 cents on the dollar. So in our historical way of delivering health care, we pretty much ran all of those people through the same delivery system, right? And the payment system worked about the same for all of them. And that's what's being changed. So as an organization, when you get into population health, you have to start using data, and you have to start using information that you have readily available to start to identify who this 5% are, and to start engineering the interventions that are going to be very different than this population at the bottom. And I look in the back of the room at your partners, you've already started to do that. Some of the folks that you're moving into your skilled nursing facilities historically would have ended up in a hospital bed. And so these are big changes. Does this make sense? This is a very simple diagram, and we can make these slides available. This is something, when you get lost in what population health is all about, just go back and look at this, because this is really what we're trying to impact. And so beyond this, the next wave that you're really going to see more and more activity on is engaging the consumer. And healthcare, if we ran grocery stores like we do healthcare, none of us would go grocery shopping. I like to use this analogy. Imagine going to a grocery store and you generally knew where fruits and vegetables and other canned products were, but nothing had a label on it about the quality of what was inside or what the cost was. So you'd kind of roam through the store with a grocery cart and you'd say, well, this feels like beans. I'm not sure it's organic or cheap brand. You throw all this stuff in your cart, you check out, and then they would say, we'll send you a bill in 30 days and let you know how much you spent. And then when you got home, you'd open it up and find out whether you made wise decisions or not. Isn't that how we do healthcare? So we give people high deductible health plans, we throw them into healthcare, they get sent all around a fragmented delivery system. They have no clue how much things cost or how to evaluate quality. My wife and I are highly activated healthcare consumers. We drive providers nuts. And we ask these simple questions. How do you evaluate your quality compared to your competitor, and how much will it cost? And normally we get put on hold. And I'm sure you can relate to this. In the office, they're going, they want to know how we compare on quality. How do we even know how to answer that? And, how do we know how to tell them how much it costs? Well, I understand. I'm not blaming providers. It's complex. How many different insurance companies do you work with? But I've shifted to this for my cost question. Will this cost me the same rate as my cell phone payment, my car payment, or my house payment? Just give me a ballpark. And even then, you get the stare, I don't know, somewhere in there. So consumers are really going to start making a higher demand of their providers around helping them understand the decisions, and they want to be shared partners. And so a lot of words up here, but it's really, you're going to see even more tools becoming available in the hands of consumers. And so you want to get ahead of that. If you start to work with different populations, you're going to want to also start to partner with these best-of-class tools. So shopping for value, and employers, which includes government, looking at engineering their delivery networks very differently around providers that can accommodate some of these tools. We have retail clinics coming in, and we have a lot of entrepreneurs coming into healthcare. So you can cross your arms and say, well, what right is it for them to come into our industry and disrupt it? There's a lot of waste in healthcare. Some think up to 30% of our healthcare is wasted. So entrepreneurs see this as a really fertile ground to make money. And while that might, not sit well with you, that's how normally disruption happens inside of an industry. So get ahead of it is kind of my challenge to COPC and other organizations. And then I won't spend a lot of time on this, but the third wave is really about the advancement of science. And you talk about disruption. This gets into a lot of the DNA work, the genetic sequencing and testing, and really all of us figuring out where we're at an individual level. So that's a whole nother presentation. So big changes coming in healthcare. And I think the takeaway from looking at those three waves, there's about $1 trillion in our healthcare system that's going to get redistributed. Think about that. That's money that has traditionally gone to certain parts of our healthcare system, and it's going to start being moved around to those areas that are demonstrating value. So let's go back to that upside down pyramid. If COPC is an organization that starts to demonstrate that for comorbidity, you are managing those patients, delivering high quality and having an impact on cost, and you're also making an impact on that middle triangle, that's where the redistribution starts to happen. People that are sitting with their arms crossed saying, I'm going to continue to ride the fee-for-service donkey until it dies, they're going to be the ones complaining about their reimbursement going down. That's where medicine is heading, whether we like it or not. So let me close on some themes that I'd like for you to think about when you consider where your organization is at with its culture. So we spend a lot of time in healthcare having a culture of distrust and blame. I get the opportunity to work with providers, with consumer advocates, with government leaders, with business leaders, and I'm here to tell you everybody's a victim. I could spend every minute of my day listening to people's victim story. Those providers, those patients, those insurance companies, those employers, we've got to get out of that and realize that we have this shared responsibility to use the scarce resource better in our healthcare system. And I'm not naive. It doesn't mean everybody tomorrow is going to start getting along. But the organizations that start to change their culture and say, we've got to start reaching out and partnering with organizations that we've never worked with before are going to be the ones that get ahead of it. So my question to you, rhetorical, is the COPC culture ready for that? Are you ready to reach across aisles that maybe you've never reached across and start to build these kind of strategic relationships? These are some of the big attributes that are happening with care teams. One is everything needs to be measured around this value proposition of quality and cost, and that this is going to result in performance-driven teams. So I know you already do a lot of comparisons across your physicians and across your practices, and that's only going to accelerate. Take a simple example of 4 to 5 common measurements of helping people manage their diabetes. And yet only about 20% of our diabetics get the 5 preventative interventions a year. So the question is, do you know where all of your diabetic patients are? And do you know where they're all against those 5 measures? That's the kind of data that's going to drive improvement within your organization. This is something that is the only way to get us out of our workforce problem. And that is, we're going to need everybody to practice at the top of their license. We're not going to grow enough primary care doctors in this country to serve all the need. So we're going to need everybody to pick up what they're capable of doing. And that's going to require culture change. Providers are going to have to start looking at members of their team and start to allow them to have the freedom to do things that are within their scope of licensure that they can do probably a better job of, so that physicians can spend more time with those patients with comorbidity. So there's going to be a big shift going on in team-based care. And then integrating care, the classic issue here is behavioral health and physical health care, that we've got to bring those things closer together. How many patients with comorbidity suffer from depression? I think it's 60%, 70%? We've got to bring these integrated care models closer together. And I think I blasted through all my time. I think I'm going to be on a panel later, and you want to hold questions for later. So thanks for your attention.